Okay, so in this video, we're going to focus on the neurotransmitters of your autonomic nervous system. So the major neurotransmitters of the ANS are acetylcholine and norepinephrine. Now, acetylcholine is used by both systems, sympathetic and parasympathetic, and it's released by what we call cholinergic fibers, which are basically all autonomic nervous system preganglionic axons. Both sympathetic and parasympathetic preganglionic axons release acetylcholine, and all parasympathetic postganglionic axons release acetylcholine. Now, what differs here then is that norepinephrine is released by adrenergic fibers, which are almost all sympathetic postganglionic axons. Except for sweat gland postganglionic axons, those actually release acetylcholine onto muscarinic receptors. Now, the effect of neurotransmitters depend on whether it binds to cholinergic receptors or adrenergic receptors. And even then, there's subtypes that have different effects. So we talked about how in the somatic versus the autonomic nervous systems, that there's different neurotransmitters are released onto, different effector organs or different neurons here. And we saw that there was a similarity across both systems, and that was the use of acetylcholine. Now, neurons that release acetylcholine, we say that are cholinergic. So it's appropriate to say then that in the somatic motor system, our motor neurons here are cholinergic because they release acetylcholine directly on a skeletal muscle. Or in both the sympathetic and parasympathetic nervous systems, the preganglionic neurons are also cholinergic because they all release acetylcholine. But where things differ between the sympathetic and parasympathetic nervous systems is at the level of the postganglionic neurons, where in the sympathetic nervous system, most postganglionic neurons release norepinephrine. So we would call those adrenergic neurons. And then most postganglionic parasympathetic neurons also release acetylcholine. So it would also be appropriate to call these cholinergic neurons as well. So there's two types of cholinergic receptors. We have nicotinic receptors and muscarinic receptors. And they're named after the drugs that bind them, that mimic these effects. So for instance, nicotine, binds to nicotinic receptors and mimics the effect of acetylcholine. And muscarinic receptors are sensitive to muscarine, which is actually a mushroom poison. And that's actually how these receptors were first identified. Now, the nicotinic receptors are found on all postganglionic neurons, sympathetic and parasympathetic. They are also found on the hormone-producing cells of your adrenal medulla and the sarcolemma of skeletal muscle cells at the neuromuscular junction. And the effect of acetylcholine at the level of nicotinic receptors is always stimulatory because, as we've learned, nicotinic receptors were ligand-gated ion channels that can allow for an influx of sodium that is depolarizing and therefore an excitatory postsynaptic potential. So if acetylcholine interacts with a nicotinic receptor, it's going to open this ion channel and it's always depolarizing and therefore always stimulatory. But that's only if it's nicotinic receptors. This differs than muscarinic receptors because muscarinic receptors are first of all found on the effector cells that are stimulated by postganglionic cholinergic fibers. Mostly the parasympathetic nervous system, but some little bit of the sympathetic nervous system with sweat glands. And the effect of acetylcholine on muscarinic receptors is different because muscarinic receptors can either be excitatory or inhibitory due to the fact that these are G-protein coupled receptors rather than ligand-gated ion channels. So it depends on the receptor type of the target organ. So when acetylcholine binds to cardiac muscle cells, it actually slows down heart rate. And this differs then when acetylcholine binds to the muscarinic receptors on intestinal smooth muscle cells because this actually increases their rate of contraction. So for the adrenergic receptors, these are actually sensitive to adrenaline, noradrenaline and adrenaline, or also called norepinephrine and epinephrine. And there's two subclasses. We have alpha and beta adrenergic receptors. So there's alpha 1, alpha 2, and then beta 1, 2, and 3. Now, the effects of norepinephrine and epinephrine on these receptors really just depend on the receptor that predominates on the target organ. So when norepinephrine binds to cardiac muscle beta 1 receptors, it actually increases heart rate. But when norepinephrine or epinephrine binds to bronchial smooth muscle, it actually causes it to relax because of these beta 2 receptors. So ultimately, it depends on the type of receptor that helps determine the response on that organ. So what this slide is showing is a nice summary of the cholinergic and adrenergic receptors. Remember, cholinergic receptors are nicotinic and muscarinic receptors, and they're called cholinergic because they're both sensitive to acetylcholine. Now, nicotinic receptors are always excitatory because they're ligand-gated ion channels that generate excitatory postsynaptic potentials. And these nicotinic receptors are found on all postganglionic neurons, adrenal medulla cells, and the neuromuscular junction of skeletal muscle. Muscarinic receptors are found on all parasympathetic target organs, and although they're mostly excitatory, there are some cases of inhibition as well, like with cardiac muscle. And you also find some muscarinic receptors on sympathetic targets like the eccrine sweat glands, and these are also activated. That increases the rate of sweat production. Now for the adrenergic receptors, we have beta 1, 2, and 3, and then alpha 1, alpha 2. Now these receptors are located in different regions. And so it's important to note then that beta 1 receptors are mostly found on the heart, but also kidneys and adipose tissue. Now when norepinephrine and epinephrine, which also called noradrenaline and adrenaline, hence the name adrenergic, bind to beta 1 adrenergic receptors, it actually increases heart rate and the force of heart muscle contraction. It also stimulates the kidneys to release renin, which increases blood pressure. So think of the beta 1 receptors found on your heart and your kidneys and adipose. They actually are going to lead to an increase in activity. So you're going to increase heart rate, increase blood pressure, and increase the rate of lipolysis or breakdown of lipids in adipose tissue. Now, beta 2 receptors here are located in the lungs and other sympathetic target organs like the blood vessels serving the heart, liver, and skeletal muscle. Now, what's interesting then here is that these beta 2 receptors are actually inhibitory mostly. So when epinephrine or norepinephrine bind to beta 2 receptors in the lungs, it actually causes smooth muscle relaxation. That way these bronchioles can get wider and increase airflow. When epinephrine and norepinephrine bind to beta 2 receptors on the blood vessels that go to your heart, liver, and skeletal muscle, it also causes those smooth muscles to relax, which causes those blood vessels to dilate, and that increases blood flow to the heart, the liver, and skeletal muscle, which makes sense during the fight or flight response because your heart needs to get more nutrients to pump harder, and then the liver and skeletal muscle are also going to be involved with, first of all, processing nutrients, and your skeletal muscle is going to help you, get away or fight. Now, beta 3 receptors are located on adipose tissue, and these also stimulate lipolysis by fat cells, so that when epinephrine and norepinephrine bind to beta 3 receptors on adipose, it stimulates the breakdown of fat. That way you can release more free fatty acids into the bloodstream, which is basically just nutrients to help your cells, and undergo the fight or flight response. And that makes sense. Now, alpha 1 receptors are located on most sympathetic target organs, especially the blood vessels of your skin, mucosa, abdominal viscera, kidneys, and salivary glands. But if you think about this in terms of, alpha 1 receptors are associated with these organs, but is it important for blood flow to increase in skin, mucosa, abdominal viscera, kidneys, and salivary glands? The answer is no. So the effect of alpha 1 receptors is it actually causes constriction of blood vessels as well as visceral organ sphincters. So the effects are mostly excitatory here in the sense that it actually causes smooth muscle of your blood vessels to contract, which causes vasoconstriction and decreases blood flow to your skin, mucous membranes, abdominal viscera, kidneys, and salivary glands, which makes sense. And it also causes the pupillary dilatory muscle to contract, which causes your pupils to dilate and get wider. And that also makes sense in terms of letting more light into your eyeballs so you can process more visual information during the fight or flight response. Now, alpha 2 receptors are located on, first of all, adrenergic axon terminals and the pancreas. Now, alpha 2 receptors actually are involved with negative feedback, so it inhibits the release of norepinephrine from nerve terminals. But these alpha 2 receptors on the pancreas inhibit the release of insulin. Now, insulin is a hormone released by your pancreas that lowers blood sugar. So if epinephrine and norepinephrine interact with alpha 2 receptors on the pancreas and prevent the hormone that lowers blood sugar, then your blood sugar is going to remain high during the fight or flight response, and that also makes sense. So what I want you all to know from this slide then are basically the locations of these receptors, cholinergic and adrenergic receptors, so where they found in the body, and the major effects of these receptors. Now, this is extremely important to know because a lot of pharmaceutical drugs actually target these different receptor types to have an effect on the body. So, for instance, for individuals with anxiety and high blood pressure, you can give them a beta blocker like propranolol. That's going to actually inhibit beta-1 receptors. So if you prevent beta-1 receptors from being activated, then you don't get an increase in heart rate or a force of contraction. So if you have high blood pressure, taking propranolol that inhibits beta-1 receptors would actually decrease heart rate and decrease the force of contraction because you're not able to stimulate these receptors. And in that regard too, it can also help you feel more calm, which is interesting. So it's important to note then the major effects and locations of these receptors because there's a lot of drugs that target them, and this would help you tremendously in a pharmacology class.